Well, I started to use years ago IPCL. I started with the first model. It was the V2.0. Before of that, I used ICL, and before of ICL, before of 2007, I use another anterior chambers lens. But I find that the IPCL and the new model is the V2 is very confident for me. It's very comfortable to use, and not just the surgery is comfortable after the surgery, and the post-op. My patient with this lens are happy, and this is the principal reason that I use this lens. I don't have any financial to disclose. I divide this talk in different way. The main characteristic of the IPCLs, some tips, pre-op, post-op, some tip of the surgery, some of my scientific studies, and we want to talk about complication also. Well, I think that you know what is IPCL. It's an posterior chamber implantable phakic contact lenses. And there are four models: spheric and toric and diffractive spheric and diffractive toric. And this is, for me, a safe and effective option to correcting refractive errors, especially when the corneal procedures are contraindicated, and it's useful to correct myopia, hyperopia, astigmatism, and also presbyopia now. And I think this is the real goal of this lens now. And okay, the material of the lens is an hydrophilic polymer with 26% of water, UV protection. The important thing is one of the most important thing I think is the overall diameter is from 11 to 14, but with different steps increasing by 0.25 millimeters. And another important thing is the optical diameter that could be customized if you have some scotopic pupil, but you must take into account that the edge of this lens could be thicker, and you must take this into account because you can produce some peripheral cataract when you choose one of these lenses, because the myopic the IPCL with high myopia could be thicker. And another important thing is this lens has many holes to prevent cataracts. 2 in the upper part of the optic, 1 in the middle, and 4 in the intermediate zone. It has 6 optics with very soft optic. I don't have any problem with these optics in the sulcus or with the sonula, because this optic is very soft. This lens has also some central hole that is conic, and I don't have problem with this kind of hole and with halo for this hole. Some patients talk with me after surgery, and they say, well, when I look some LED light, I can see some circle around the light. Well, I need to always explain about that this is the hole that improve the movement of the humor, the aqueous humor in the anterior chamber to the posterior chamber to the anterior chamber. And the patient, when we explain that situation, understand, and they feel confident with that. But it's not a real problem. Some patient can ask about that, but it's not a real problem. And The other important thing that is the intermediate sound of the lens, that's the angle between the optic to avoid the excessive vaulting. This is, for me, is one of the most important sound that has to the lens the real structure of the lens. The main diffractive characteristic is an diffractive and refractive wide trifocal optical design. There is between 5 to 9 ring, depending on the addition for the near vision, from 1.5 to 4, and with also the intermediate addition in this for this kind of lens. I prefer to choose depends of the age of the patient and the myopia until 3.5 of addition. And the pre-op studies, indication, contraindication, and post-op follow-up. I need to know in this patient everything of because in this kind of patient the eyes with high myopia or with myopia, and we need to know how is the cornea, how is the retina, how is the intraocular pressure, and we need to know also some details of the eyes, wide to wide, sulcu to sulcu, angle to angle, the iridocorneal angle, and we need to know really when we need to exclude some patient, and when the patient has less than 2,000 cells by millimeters. We know that the lens is in the posterior chamber, but we need to have these considerations. The ICD less than 2.8, I prefer when you start with this lens, taking account the 3.0 or more from the endothelial to the crystalline lens. Patient with cataract, history of glaucoma, retinal surgeries, corneal disease, dystrophia, degeneration. And the inclusion criteria is with myopia more than -6, or thin cornea with myopia also. And now patient with myopia or also emetropia for presbyopia, I start to use this lens. How I choose the addition for this patient? I think always patient with myopia and astigmatism. Astigmatism when the patient has more than 1 dioptria. But it's one consideration that I take on account in this patient, that when the patient has more than 1 dioptria, but from just the cornea, from the pentacam, I don't take in account the total astigmatism. I just take in account the pentacam or the corneal astigmatism to correct in this patient. And I have very good result with that. I know that many of the doctors take in account the total astigmatism, but in my experience, I just take only the corneal astigmatism. And all of the patients want to glasses independence. The same indication and contraindication for the normal IPCL. And now I start to use this lens when I find a very good anterior chamber and very good angle in patient with emetropia. And I have very good results, but I don't have so much patients with this emetropia. How I correct this patient? Well, first I take into account the best corrected subjective far side, I correct in the best way like that. But always I take in account not just the subjective vision, I take in account the cycloplegical refraction of this patient. And when I have so much difference with the subjective refraction and the cycloplegical refraction, I take into account the cycloplegical, and maybe I put 0.5 or 0.75 more, but no more than that. Because if you put the subjective refraction, we can have a surprise after surgery, refractive surprise after surgery. First things is evaluate the far side, and after that I evaluate the near side, thinking not just by now, I thinking for the next 5, 10, 15, 20 years, depending on the age of the patient. It's different for me when the patient is, for a young patient, I have my personal formula, it's the blend, different addition, the dominant eye with lower addition, but the most addition that this patient tolerate for this side. And in the non-dominant eye, I put a little bit more, 0.5 or 1 diopter more if this patient tolerate. I call this blend. And this is because I think in this patient for the near vision, no, by now, I think for the next years. And I want that this lens could be useful for the patient for until they need to operate the cataract. But in some patients, that situation is not tolerated, and I put the same addition in both eyes. But the higher that this patient could be tolerated. And also, when the patient have more than 10 diopters, I choose the higher addition, no matter the age. I choose 3.5 in this kind of patient. Well, next one. Pre-op studies, complete ophthalmic examination with the peripheral retinal evaluation and posterior OCT for macula and optical nerve evaluation. It's important also the ocular surface evaluation because we will use a diffractive lens, and we need to know how is this ocular surface, and if the patient has dry eye also, we need to know that. And I treat because many of these patients are use the contact lens for many years. Also, the ocular motility. We need to know how is the motility. We don't want to one surprise about that. We need to know before surgery. Also, the pupil diameter. And now, actually, I evaluate in different light conditions the pupil diameter. I do the higher master, pentacam, UVM. UVM for me also is very important. And I say before the refraction, objective, subjective, and cycloplegical refraction to select the IPCL power. The UVM is very important because we need to know we need a very good bolt after surgery. And sometimes appear some cyst in the sulcus, sometimes, but sometimes it's frequently find cyst in the sulcus. But not always is important for the bolt, but we need to know first before surgery, because sometimes we need to change the lens if the bolt is too big or small. In this case, if we know before, it's better because we talk before with the patient about that. Well, in some case, we have very good anterior chamber, but we have some angle that we need some iridotomy before the surgery, or in some case after surgery, to prevent the angle look. It's very important for me to have the IOL master wide to wide. This is the first that I take in account to have the size of the lens. I have this result. This result is about the wide to wide in 100 patients. This is the wide to wide of the IOL master. And this is the diameter of the IPCL, 0.7576 of difference between the IOL master with the size of the IPCL. This is a special case with a high extreme myopia, minus 31, and I choose the cycloplegical refraction, and we can see the peripheral bolt is without touch the crystalline lens. We need to know that thing because we don't want to have the peripheral cataract in young patients. This was a really good case, and for me, and the patient was really happy with this correction. Well, we need to check and control the patients, the visual acuity and refraction, and I make some satisfaction questionnaire after surgery, and I check also the IOP and the cataract evaluation at the slit lamps, specular microscopy, pentacam to know how is the astigmatism after surgery. The UVM is very important for me to evaluate the bolt after surgery and the stability of that, and the OCT also for more information about the bolt. How I made the surgery? Well, my personal technique is that I make that with both cameras, and I prepare the lens before to start surgery, and I put in the cartridge. In my case, I prefer without viscoelastic, just with VSS, and I need to know that it's perfectly in the cartridge, and after that I try to put the lens to the end of the cartridge, and I need to know that the lens is in the correct position. We need to charge this lens with the same of another flat lens. After that, I made an incision, 20 gauge, and I introduced the irrigation cannula of the bimanual irrigation cannula. I inject the lens inside of the anterior chamber, and I put the lens behind of the iris. I made some rotation to put the lens from 0 to 180 degrees, and after that I put some BCS and antibiotic in the anterior chamber and also in the cornea. And this is the surgery. One of the important things with my technique is that I don't have peak of IOP after surgery. I don't have touch because I don't have to clean the viscoelastic under the IOL. And well, I think I have many of advantages about the technique, but I know that when you start with this lens, or when some people are confident with viscoelastic, and if you feel confidence with the viscoelastic, you need to use viscoelastic, and it's very important to clean the viscoelastic after surgery. Sometimes with the same irrigation cannula that I use, I put in the center of the lens, in the center hole that have the IPCL, to clean very well this zone and remove all of the viscoelastic in the anterior chamber and also under the lens. This is my experience with IPCL. You can find this in PubMed. You can look Bianchi GR, and you can find this work. It's about the first model, the V2, my first 100 consecutive IPCL surgeries. And with this model, and I evaluate the spherical equivalent, the corneal endothelial cell density, because I made the surgery without viscoelastic, the corneal central thickness, IOP, the volt, with 6 months of follow-up. And with this result, just reduced 2.9 cell density, and the corneal central thickness was okay, the volt was stable, and the IOP also was stable without any peak after surgery. Baseline 1 day, 6 months, and no cataract was developed in any of these patients. This is the result of the deficiency of the spherical and the cylinder refractive results, with very good results. And this is another study, the diffractive phakic posterior chamber IOL for presbyopia. You can find also in PubMed. And this is a little...
Hi, I'm Natasha. I had intraocular lenses implanted the day before yesterday, left eye, and the right eye a week before that. Right now my vision is very good. I can see from a distance, and also close by very, very sharp. I don't see halos, I don't see anything strange. I just do feel I have to adapt to the new situation a little bit, but my vision is very good. And I used to have myopia, negative 4 or 5 more or less, and I use glasses and contact lenses. So right now I'm very happy I don't have to use them anymore.
Okay, this is one of the patient that I made this surgery with the presbyopic IPCL. She was one of the first. She has 42 years old, and I chose this patient with addition of 2 and 2.5. So, well, this is another surgery, just for show you. It's the same way that I made before, that you can see better here. It's the same surgery that I make always. You can see the lens inside of the anterior chamber with a very good correction. Well, this is the nomogram that I made to select the different addition, but I told you before how I choose. I take in account not just the age of the patient, taking account the myopia, and I have 2 options, option A and option B, depend the both with the same addition and the same and the different addition depending on the age. but I always think how addition tolerate this patient, no? The result of this study is like here. Patient with between 40 to 55 years, all with myopia and with or without astigmatism. And I have a very good result without any statistical significant difference between the endothelial cell density, the corneal central thickness, the volt was stable, and the IOP was stable. This study was with 12 months of follow-up. No cataracts were developed in this patient, but I know that I have from 2015-16 that I started with this lens, and I just had one patient with cataract. This is the refractive result. The coefficient of determination was near to 1. I have very good result, refractive result after surgery with very good vision, and the patient are happy. That is very important after surgery. And we need to know one important thing is the binocular defocus curve of this lens. We need to know that this kind of patient have some trifocal lens that work together with the residual accommodation of the crystalline lens. And I think this is good for the patient, and maybe for that reason is that the patient have no so much halo after surgery, and it could be one of the reasons. And this is another work that I made, the IPCL under different light conditions, scotopic, mesopic, and photopic. You can find this way. You can see how the IPCL move under different light conditions, and when the light intensity change, we were able to register a shifting volt slightly lower than 100 microns. And I think it's important because when we have a volt less than 100 microns, we need to think to change this length for another 1 or 2 size more than that. This is the presbyopic correction in metropia. The patient with 50-year-old with very good and corrected distant visual acuity without any ocular problem, no cataract. This is the refraction of the patient. The patient asked to me, what can I do? I don't want to use the near glasses. Well, I made the surgery, and I put in the dominant eye +2 and in the non-dominant eye +3 because the patient was with 50-year-old. For the far side, I choose with the lens with +0.5.
Bueno, acá estamos con Luis, que se operó con IPCL
There is some subtitle there.
para ojos hemétropes. El ojo derecho hace una semana y el ojo izquierdo
Plus
hace 48 horas. Luis,
0.5.
¿cómo estás? ¿Cómo te sentís?
Muy bien, me siento muy bien y veo muy bien y bueno, ni necesito anteojos.
¿Y cómo estás con las luces en la noche? ¿Te molestan las luces, las halos? ¿Ves algo de eso?
No me molesta.
¿Las luces de los autos de frente te molestan?
No, eso 100% no tengo ningún problema.
¿Acá ves?
Sí, eso veo perfecto. FZB, B larga, D, O, F, L, C, A, P, E, O.
A, B, E, O.
¿Y acá?
También T, Z, B corta, F, E, H, P, N.
This patient has more than 20/20 for far side.
Y entre miles de columnas penden hermosas plantas. Para
Checker one for near
Sí,
side.
lo veo perfecto.
It's a happy patient without halo, like he said, but well. I think it's another consideration for this patient to take in account to correct the presbyopia in a metropic patient. I know that is not a surgery for everybody, but we can take in account for some patients that they want to correct the presbyopia and they want to live without any glasses. Well, finally, complications. I think it's better to explain always before surgery than to justify later or after surgery. You must be careful in patient selection. You must follow your patient after surgery. Always, I follow my patient. After 6 months, I made some study like UVM, OCT. I studied the retinal. I need to know how is the patient, how is the vault, how is the cornea, the endothelial cell density, and if the patient has cataract or no. What happened with the vault is low or high. Both is not good, but when it's not good. I know that it's a reversal surgery, and it's a very important thing. You can replace the lens directly or remove and avoid cataract if the vault is so small, but I don't know. I don't find any endothelial problem with that, but I know when the patient has a high vault, we can have problem with the iris. Well, this is how I replace the IPCL. I show you some surgeries. There is the ICL that I in the left side, and I replace because the ICL was rotated, and the ICL don't have the size for this patient. That this patient was to use the same lens ICL after surgery, but he don't have the ICL don't have more than 40 millimeters, and we need to choose one of the lens. And I change for an IPCL with more size. It's the easy way to take out the lens. The IPCL has some hole that is easy to remove, and I put the OVD in the anterior chamber and under the lens to put the lens in the anterior chamber. With the same cannula, I move the lens. I don't have any synechia, never in the iris or in the sulcus, and I don't have cataract in the periphery of the lens also. And look, and I put the same OVD cannula of methyl cellulosa, and I take from the hole, and I just put the McPherson to take the lens out with 1 or with 2 McPherson. And after that, with liquid, I inject the lens again inside of the anterior chamber. In this case, with a size because we need volt. I change no more than 5 or 6 lenses, no more than that. When I have in one patient for the high volt, and another 1 or 2 patients with the small volt, and the other patient was because the toric lens was rotated. And when the toric lens is rotated, I need to put another lens because the astigmatism is without any correction. But I talked before surgery that the patient could need another surgery, and it's just a few percentage, but the patient are waiting for the new surgery when something happens, and they don't have any problem because I talked before about that. Well, uh, another complication that I have because I use is just the only one that I have. The optic was in the I need to change. Yeah, when the lens don't go well to the end of the cartridge, I need to charge again, because if not, I have the rotated upside down inside of the anterior chamber. I charge again, and when I charge again, in this case, it was with the problem because I catch my optic in the end of the cartridge. Well, it was with the solution in the same surgery because I have two hands only. But well, another doctor take my right hands, and I could move the lens inside of the anterior chamber, and I put after that in the posterior chamber, and it was good. It was just a complication. And we used to say that if you are a surgeon, you have complication. And cataract. And I have one patient with cataract, just one until now. I hope so, continues like that, but I have very, very good result. And it was because it was some mistake for the correct size of the IPCL, and I always say maybe you could have some cataracts, and this patient understand about that. This is another thing that could happen in some patient, and with just the light of the slit lamp, you correct this thing with the iris and the lens. And when it's correct, I don't have any problem after this. I'm sorry, here is the patient with the cataract. I take out the cataract and I put lens with the correct astigmatism. And I think we need to change the lens just when the cataract is important. If the cataract is not important, sometimes we need to remove the lens and put another lens with the. This is the cataract. You can see here a little anterior subcapsular cataract. And I made the cataract surgery, and I put the intraocular lens, and the patient was happy. Just the only one that I have. The surgery is easy, you know that. In this case, I put a trifocal lens. This patient has 6 diopter of astigmatism, and well, now this patient is happy. Undersizing, oversizing is important. The preoperative measure to avoid the mistake. The refractive surprise, in my experience, we need to take in account the cycloplegical refraction is very important. If you always do that, you maybe don't have any refractive surprise. There is many complications, many words about complication, the task after implantation. I don't have task after surgery because I don't use viscoelastic. But if you need to use viscoelastic, I use methyl cellulosa and I use Ocucoat, but I don't know if you have this methyl cellulosa there. And there is a lot of Rett-Savalia syndrome, but there aren't any presentation around the world about IPCL complication. This is another more, but well, I think pre-op evaluation for avoid problems, post-op follow-up, good practice of implanting IPCL is necessary. Well, I think it's a good option for myopic patient. The diffractive IPCL indication are growing, also for emetropic, for some of emetropic patients. I have 4 years of follow-up. For the future, we need more study from a wider range of patients and also from different surgeons, different countries, observing and evaluating the behavior across time. And always, I invite you to perform a collaborative international study. It could be very good. And this is just 9 injecting in the anterior chamber. Just you can see how the lens is moving inside of the anterior chamber with BSS. It's always the same. Well, I don't have a problem also with the peripheral angle of the iris and cornea when I put in this way. It's just the way that I used to make the surgery, and I like to do that because I have very good result with this technique. I hope somebody like this, and I do this surgery. Sorry about my